Good morning, everyone, and thank you for joining us. This is a telehealth immersion program session focused on leveraging EHR-integrated telehealth tools to improve the patient, physician, and care team experience with virtual care. My name is Bernadette Lim, Program Manager on the Digital Health team here at the AMA, and it's my privilege to introduce today's speakers, Dr. Hasselfeld and Dr. Hughes. Dr. Brian Hasselfeld is the current Medical Director for Digital Health and Telemedicine at Johns Hopkins Medicine, focusing on digital health, virtual care, and clinical innovations. In addition to his role as medical director, he also serves as a primary care physician in internal medicine and pediatrics for Johns Hopkins Community Physicians and is also on the board of directors for a regional Medicare Advantage insurance plan. Dr. Helen Hughes serves as Associate Medical Director for Johns Hopkins Medicine Office of Telemedicine and Medical Director of Pediatric Telemedicine for Johns Hopkins Children's Center. She is currently serving as one of 3 telehealth and healthcare equity experts for the Association of American Medical Colleges. Before turning it over to Dr. Hasselfeld and Dr. Hughes, just 2 quick reminders. We will be reserving time at the end of today's presentation for any questions that you might have. You can type it in the chat below at any time throughout the session today. And then this presentation will be recorded, and we have a brief disclaimer on the next slide. And with that, I will turn it over to you, Dr. Hasselfeld and Dr. Hughes.
Great, thank you so much. We appreciate the opportunity to be here with the AMA and for all those attending. Dr. Hughes and myself will go ahead and dive right into some of our early data that drove the intervention that we're going to discuss today. On our first slide here, you'll see our typical journey through the COVID-19 pandemic for virtual care at Johns Hopkins Medicine, reflective of the experience that many have endured throughout the pandemic. Pre-pandemic, telehealth offerings were targeted and niche across a very niche patient population, 50 to 80 visits per month, a little over 500 in the preceding months before the pandemic began in March of 2021. Since then, over 1.1 million total visits, in blue seen in video and in orange seen by phone. We've obviously stabilized around mid 30,000 total visits per month, up from that 50 to 70 per month pre-pandemic, but down from the peak of nearly 100,000. The key point here, and what Dr. Hughes will highlight, is that as we begin to watch these trends, the orange bar, phone visits, while compressing and stabilizing somewhere between 14 to 16% of our total visits, that percentage distribution was not allocated similarly across different patient populations. I'll turn it to Dr. Hughes.
Thanks, Brian. So to lay the foundation for a simple tool we developed that we'll be discussing later, we wanted to talk a little bit about our work in developing a dashboard around telemedicine equity and telehealth equity that laid the foundation for that initial tool. This is a commentary that we published with some of our colleagues in our Center for Health Equity about a process that we use to develop a telemedicine equity dashboard that we found helpful in informing some of these efforts. This is a screenshot of our current telemedicine equity dashboard, which is a 1.0 version. We hope to have future iterations. We have found % of our telemedicine visits that have been by phone as compared to video as an initial marker of telemedicine access disparities across our health system. So of the over 1 million visits we've had in the top left of the screen, you can see that 18% have been by phone versus 82% by video. And when we look at different demographic patient groups, we can see that the distribution of phone visits is not equally distributed. So when looking by race, you can see gray bars are telephone visits versus blue bars are video visits, and the N is on the right side. We have higher rates of telephone visits, encounters in groups of patients who identify as Black or African American and American Indian Alaskan Native, in patients whose preferred language is Spanish or Arabic in comparison to English, in patients who are in older age groups as a comparison to younger age groups. And by payer, we see that 8% of encounters with patients who are privately insured are by telephone versus 27% of patients who are Medicaid insured versus Medicare insured. And this has been helpful, particularly in our state of Maryland, as we passed our state passed the Preserve Telehealth Access Act of 2021 this spring, understanding that telephone visit access is really a health equity issue. This shows geographically, prior to the pandemic, perhaps broadband internet access and digital access was definitely felt to be a rural health issue, but we've seen that it is definitely an urban health issue as well. This shows percent of visits as telephone in dark blue as 0% and dark orange as 50%. And we can see that in East and West Baltimore, with Johns Hopkins Hospital kind of being in the middle of this butterfly pattern in the middle of the slide, that we have pretty high rates of telephone visits. This maps pretty closely to the 21st Century Cities Initiative map here of seeing wired broadband access in Baltimore City. But certainly broadband access isn't the only issue here. Other issues related to device access, comfort with devices, knowledge of technology, trust, privacy concerns are layered on top of these broadband internet access issues. This is a map by zip code. H here in the center is where Hopkins Hospital is. And so looking at a few of our zip codes right around our neighboring zip codes from the hospital, we can see that 21205 and 21213 right northeast of Baltimore have 35% of visits and 37% of telemedicine visits as telephone in comparison to an 18% institutional average, and also in comparison to 12% in the neighborhood of Roland Park in North Baltimore. And this maps to a number of outcome disparities, including life expectancy across our city. And when we layer on populations, for instance, looking at older patients over 65 and zip code, we see even more stark disparities with, again, 0% phone being dark blue and dark orange being 50% phone. We're seeing a lot of dark orange in East and West Baltimore here in patients over 65. And when we look at those same zip codes neighboring our hospital, we see that of all telemedicine visits, 59 and 58% have been by phone in the 65 up group in these zip codes, in comparison to what is 26% institutional average and 16% in that Roland Park neighborhood. So I think I'm going to hand it off to Brian, but kind of the overall summary here is that we've noticed that our telemedicine services are not accessed equitably by all populations, and some of what we'll talk about later have been initial steps to kind of figure out how we can target care to different groups in the ways that meet their needs.
Thanks, Helen. And so to further validate the signals that perhaps not unexpected, but still important coming out of our patient access data, we went to our clinicians and surveyed all 3,600 who had completed a telemedicine visit and got over nearly 1,300 responses. And one of the important questions from that survey was, what are your perceived barriers for your patients? And again, perhaps unsurprisingly, basic technical functions rising to the top, basic internet connectivity being the #1 issue, and then proxies for internet connectivity being issues 2 and 3, audio video connection issues. And so clearly throughout the pandemic, telehealth, an important aspect of care delivery, maintaining both new and established patient connections across the specialty landscape, but having some basic technical issues get in the way, perhaps, as Dr. Hughes mentioned, of equitable access across different modalities of telehealth. And so we began to think about ways to address that. On the next slide. We published in the Harvard Business Review a subjective qualitative description of our approach. We're going to dig into the technical approach a little bit here on the subsequent slides, but kind of built on that fact that we use the EMR to help us guide a lot of things, both clinical, but importantly also non-clinical, things that are traditionally viewed as non-clinical, but have really meaningful clinical impacts, ranging from operational questions like show rates and transportation barriers to increasingly important focus on blended areas underneath social determinants of health. And we thought that the same could be true for video visit readiness. How can we use information already present in the medical record to drive a basic risk score around prioritizing patients that may need improved or increased effort around their video visit for mostly technical intervention. Similar in my mind, it takes transportation to show up to an in-person visit. It takes technical readiness to be there ready in your waiting room for your video visit. And how can we be a little bit more predictive while also acknowledging another real strain on the healthcare system currently? Support staff like provider staff are currently overworked and perhaps under-resourced across the delivery system. So a finite resource, and how do we optimally deploy that finite resource? So moving on to our next slide, we'll dig into a little bit more detail around what we built and the ways that we attempted to use it. So a simple 4-point scale, 0 to 4, color-coded inside the medical record and usable both by central teams as well as local care teams, visible both on the regular provider schedule, as well as on our front desk view inside of our medical record, to allow full visibility into the tool and allow it to be used in multiple different areas. We hypothesized that a few important things could be true and important in being able to predict those that may need increased video visit support. Like many Epic institutions, our patient-facing portal is Epic's MyChart, and our video visits, like many Epic institutions, are broadly accessed through the patient portal. So not having active MyChart becomes a very big barrier, potentially, for those attempting to access video-based care. Of course, we've created other workarounds to help improve and overcome that barrier, but a barrier nonetheless. Second, once inside of MyChart, once inside of the patient portal, telehealth visits, like all visits, show up as appointments. But unlike other visits, in-person visits, the electronic check-in process is your only check-in process. You're not going to a physical front desk. And inside of the electronic check-in process, you do a lot of important things that can become incremental barriers to accessing your video visit. You address regular routine health questions, medical history, medications. You upload your insurance card, but you also sign important documents about consent, including new aspects of telehealth consent that vary by state. All of that adds up to work required by somebody, either patient, support staff, or both combined. So not doing that, additionally, perhaps a barrier and a risk factor. And then lastly, are you familiar with our video visit process? And these are two mutually exclusive points. Both had no recent video visits, so you really have had no visits. You haven't tried, you don't know the workflow, or you had a scheduled video visit, but it became an audio only or a phone visit. So as important as not having done any video visits, you've attempted to do a video visit, but it became audio only. The why, obviously, unknown, could be many things, technical or non-technical, but you didn't get the full video visit experience, all of that adding up to our 4-point scale. We'll get a look at what this actually looks like on our schedule. So this is the Epic multi-provider view or multi-provider schedule view, how most of us typically see our patients scheduled across our ambulatory schedules. And so created a custom column, color-coded as discussed, green at 0 points, yellow at 1 and 2, and red at 3 and 4. And with a traditional EMR hover to discover function to be able to dig into, once you see the risk score, identify where your intervention point may be. At the top, you can see a patient with no risk factors, a green 0, and at the bottom, 1 risk factor, a yellow 1. Building up, still then a yellow 2, and then a red 3. Seeing that no MyChart bumps you up, building up towards that 3 risk area very quickly, and moving you into the red category. And then lastly, the full 4-point red category, again, that those last 2 points are mutually exclusive, either no video visit in the last 3 months or video visit in the last 3 months, but it became a phone visit, indicating kind of the failed video visit. And so on our next slide.
And Brian, this is just the front desk staff view in addition to the multi-provider schedule view.
Great, thanks, Helen, for calling that out. Just to call out that our staff live in a little bit of a different view, so we lost the flexibility of our color-coded system, but still with full functionality on hovering over there for our patients to be able to bounce between providers and between schedules easily and be able to sort by that same risk factor and see all of the important detail. The last piece of that intervention that we focused on was identifying risk is only as good as the ability to act on it. Obviously, patient outreach ahead of visits is an important component to any visit journey, inclusive of telemedicine. And we also acknowledge that over outreach leads to potentially poor patient experience or perceived patient satisfaction. So all of our patients, like in many systems, receive standardized outreach at various intervals before the appointment to remind them about the appointment, remind them to do important aspects of the appointment, both for in-person and telemedicine, remind you about checking in, for in-person care, remind you about COVID screening, et cetera. We built in the additional tool to be able to sort by risk score and be able to trigger manual outreach with custom-built SMS texts that reminded patients that video visits are hard and that we have resources here to help you. And then created a way to track when that outreach was sent, both by date and how many days ago for easy interpretation, to ensure that if different teams, either local or central, this is our central IT team intervention view, were to go back and resort and re-outreach, an easy way to identify if that patient had already been pinged with an SMS message today or yesterday, perhaps not the best time to continue resending. So a good tracking methodology for the primary intervention, which was SMS text outreach.
Thanks, Brian.
So back over to Helen here to discuss how we transition from that view, which was a central team, to applying these tools locally.
Yes, great. So the original kind of inspiration for creating the tool was to support that central pilot that Brian just discussed. But as we created it for that purpose, we realized it had a lot of application to our non-central frontline teams in our clinics across our institution. So these are some of the instructions we supplied to our CMA support staff, many of whom throughout the past 20 months have been helping patients to set up for video visits at different types of clinics across our health system. So we included instructions for them about how to add the column to their schedule that they're using day to day to help support providers and patients, how to hover to discover to see that tool, and then provided some more specificity around what to do based on what the tool was showing them. As Brian mentioned, trying to conserve resources, we were getting feedback from patients. Please don't call me if I've already done this before. I don't need an additional phone call to walk me through this. And we were getting feedback from CMAs. I'm calling patients, they're not answering. Is there a way to decrease the number of prep phone calls we need to do? So we decided if a patient had a risk score of 0 to 1, we would tell the staff, no need to call the patient in advance of the appointment. If they join independently on their own, you're going to see a green camera icon on your schedule. And then you can join that visit yourself as the support staff member and do your intake on the video. If the patient hasn't done their e-check-in process, electronic check-in process prior to their visit, you can send them a text reminder, an one-way SMS in our system to remind them to e-check-in. And then if that hasn't worked, then try to give them a phone call. But our hope was that this would prevent a lot of phone calls for patients who already know this process well. For patients for higher risk score, we ask them, please do continue to reach out to patients. If you see that they have MyChart active, give them a call and try to help them get into their visit through the MyChart process. I think as Brian alluded to, that has some advantages for our system, allows them to sign documents electronically. And so that's our preferred method. But if they don't have MyChart, skip to a different process. So we had people, spending 40 minutes at the time of an appointment trying to get someone activated on MyChart to get them in to their video visit. We realized quickly that that really wasn't sustainable, and so wanted to have ways outside of our electronic check-in process to get patients into video visits. So we told our staff, if they don't have MyChart and you're noticing a high risk score, give them a call and skip straight to texting them a visit link outside of MyChart. This is a screenshot of how they could do that. They can send a link to a mobile number on file or send them a MyChart message. I think we're soon going to have the ability to email them a link as well. And so that can get the patient more quickly into their visit. However, they may need to be verbally consented for some of their care, which is a lot of work for our staff. Back to Brian for our takeaway points, and then really excited to do some Q&A.
Great. So first, as we thought about potential interventions for a particular issue, obviously measuring and understanding the signals in the data was critically important. None of our work towards building risk score interventions would have happened without being able to visualize why did we have an issue and where did that issue exist. So the dashboarding work to build up and create differential breakdowns between accessing telehealth care across our ambulatory spectrum was critically important. Second, thinking about ways to deploy different interventions centrally versus local, building an EMR-based tool that can function in both worlds, in both support models, was equally important. And the further away you get from your local operating unit, acknowledging that thinking about other aspects of the operational workflow is important. So tracking that last intervention from a central team needs to be thinking about how frequently we're contacting that patient from the local clinic. And that in the end, just-in-time support for telehealth visits remains an important barrier for us. That central and local teams will continue to work together to think about the best ways to both prepare a patient preventatively when possible, but also deploy just in time, given natural human behavior of waiting to the last minute for executing on some of the issues related to our telemedicine care. So we learned a lot of good lessons here, and I think a lot of iterative changes still underway inside of our delivery system. And so with that, Dr. Hughes and I will certainly open it up for any Q&A about our telehealth data, our risk score, our intervention, our approaches going forward. Oh,
Bernadette, you're muted.
So we had two, while we wait for Brenda, we had two potential questions in the Q&A. One we addressed, which is that this tool is available across all of our ambulatory care, was not only limited to one particular area, and all of our specialties across all of our ambulatory outpatient footprint have been conducting telemedicine, and both our telemedicine visits are generally available for continuity of care providers, as well as same-day acute issues when needed. So certainly deployed our telehealth resources and our interventions to be both central and local and built around continuity.
Looks like you're unmuted, Bernadette. Do you want to try again? Oh, no.
Still mute.
We can keep going through in chronological order if that's okay. So I see another question around provider continuity with patients. Certainly we believe that's really important. I don't know, Brian, if you want to talk a little bit about some of the GHCP offerings, but I can just at least speak to for our school of medicine specialties. At least for much of the past 20 months, almost all of our providers have participated in telemedicine. So I think for the past 20 months, it's been fairly easy for patients to see their established in-person providers for telemedicine care. As we move back towards a new normal, and we have shifting dynamics of how much providers are offering in person, we're still kind of trying to figure that out, how to balance the patient's desire and need to see their preferred established provider versus providers' needs to have certain amount of in-person clinic and or some providers' preferences to do more telemedicine than others. So we're still kind of figuring that out in the long run, but certainly understand that finding ways to connect established patients with providers via telehealth is important.
Yeah, the scope of our presentation here isn't necessarily to expand into some of the comparative aspects of telehealth versus in-person care, which of course are critically important. Do see a few questions around that. I think the focus here is ensuring that we can overcome potential technical and digital literacy barriers and think about strategies for addressing those issues. Of course, our system and many systems acknowledge that there isn't always just two choices, come in person or come telemedicine. There is always a third choice, which is I'm just not going to get care. We're of the belief that accessing care is a good thing, and it has always been their traditional clinician role to then further triage and understand what venue of care is most appropriate. It used to be only emergency room, urgent care, ambulatory. There's now a fourth component, which is virtual, and we think that that's good for patients while retaining the traditional appropriate venue of care role of the clinician. We want to make sure that all four of those sites of care are open as equally as possible across patient populations. And that's the focus here from our talk today. Eileen calls out about broadband availability. And earlier in the presentation, we highlighted that our maps of audio only, our phone only use map very similarly to our broadband penetration in Baltimore City. And we're very thankful that the city of Baltimore and the mayor's office has made that a priority. We do believe that that is a partnership, that is an infrastructure investment question that's critically important. Broadband access has been an important determinant of health, but it perhaps is now an even more important determinant of health going forward, and will take a lot of partnerships with important infrastructure community members across our cities and rural areas alike. While we work on that with our other important public policy partners, public policy change to identify ways that audio-only care can additionally be an acceptable access point in our complex insurance space in the United States is an important public policy piece for us. We believe that while we work on joint areas of opportunity to improve broadband access, it's important that we have the public policy flexibility to leverage audio-only care where clinically appropriate. And that's one of the lessons that we saw from our early equity data at the beginning of the presentation.
Can you guys hear me?
Yes.
Apologies for that. I would love if you can just talk a little bit more about just the coordination and implementation process. So I think like this is a really incredible setup that you all have implemented at Johns Hopkins. Can you just talk about how you can coordinate this work across like, you know, all different teams, and then also like what that implementation process and building that into the EHR system looked like for you?
Helen, if you're...
Yeah, I mean, I think our office is a little bit of a unique centralized role, at least in comparison to our institutions. I've only ever worked at Johns Hopkins, so I don't have a lot of comparison to other institutions, but in comparison to other offices at the institution, we kind of sit at the nexus of multiple pieces. We are connected to the Epic Health IT piece. We are connected to our billing teams, our legal teams, compliance, marketing, et cetera. So it's really nice that we get to form all these relationships across the institution. However, it's very hard to reach all providers and all staff. You know, we have 3,600 people who have completed a telemedicine visit, and how do you operationalize something to that large group of people? Certainly, I think this tool has not realized its full potential because we haven't yet made it a required column on our schedule. It's kind of, we've educated groups to add it and use it as an optional tool. I think the places where we've had the most success in operationalization is in things that we've required. So for instance, in some of our billing workflows where there's been, you know, new telemedicine billing, we've kind of used tips or tricks in Epic to make things a required field for providers. So when something I think has to be operationalized, that's kind of where to go, is to try to figure out the technical tools that can make it both easy and necessary for the providers to do it. This so far has been more of something that we've trained people and kind of spread through word of mouth.
That's great. I had a question too, just around just like patient feedback. Can you talk about just what the patient response has been, or any other kind of outcomes in, you know, data that you've been collecting so far?
Yeah, I think we have a few different insights into that, and some of it gets into the evolution beyond just a tool. That in our first iteration of using the tool, we were SMS heavy. There's benefits to being SMS heavy because it's asynchronous. You can text and not have to have someone else on the other end of the line and wait for a response. In our second iteration, we added in auto outbound calling, and just the acknowledgement that perhaps the patient population most at risk for technical issues would prefer to discuss verbally, and had a little bit higher uptake with outbound calling from a central team, obviously recognizing that there's increased cost, obviously, with outbound calls and the amount of time that it may or may not take. And then third, and this gets to one open question around virtual only providers versus hybrid sessions. We've then kind of acknowledged that in addition to identifying risks on the patient side, there's, and this gets to your previous question, Bernadette, around how to incorporate into workflows, that you know, staff across the healthcare system are trained to participate in clinical care. We all know that both clinicians and support staff do a lot of non-clinical things, filling out paperwork, finding appointments, but no one on the care team was really trained to be IT support, in addition to being everything else that we are for our patients. And so those areas that have transitioned to virtual only sessions and allowing some training and specialization allows them to act more efficaciously around the risk score and around technical readiness. So that's kind of our third iteration, is around identifying those virtual only teams for the day or for the session, and allowing that next layer down of specialization to be able to grow the ability to intervene successfully. We all know at our local practice, my staff members know which radiology site to go to, which pharmacy to go to, where to park. And similar local knowledge applies to overcoming particular aspects of new workflows, including virtual only workflows. So I've had a little bit of early payoff and success in some of those efficiency gains as well.
Let's see. Any other questions from the audience? We have one that just came through.
We can certainly share our email addresses for those who are Epic-based and would like to meet with our Epic build teams to learn more. We're always happy to do so. So we can go ahead and put that out there for you all into the chat.
Brian, you may have mentioned this in the presentation, but remind me, who is providing the additional technical support on the team? So who's making the phone call, or who's reaching out to the patient and walking them through?
Yeah, and we briefly touched on two different approaches. The first was piloting a central-based team that was assigned particular clinics to review their virtual schedule and outreach, away from leveraging local resources, really only focused on the technical readiness aspects. That's a central IT support team. As we briefly mentioned, we had some difficulty in ensuring conversion around that. So whether it was SMS or SMS plus phone, we had essentially low uptake. And one of the lessons learned from that central IT support approach is that, and we briefly touched on this as well, sometimes human behavior takes over. I'm not sure how many people registered last minute for this webinar, but we see a lot of last minute just-in-time behavior around accessing patient portals and e-check-in, which means patients, like all humans around our activities, aren't really ready to get ready until it's time. And so that decreases some of the efficiency gain of having centralized teams versus local teams that are there and built to be on demand at the moment for the visit, right, just in time, and staffed to that type of ratio. So we ensured that the tool was available to our local support teams, our local staff that support visit schedules, both virtual, hybrid, and in person across our local clinics. And there is some benefit to that. Patients know that staff often, and that staff also knows particular local workflows and questions beyond just technical readiness, medical readiness as well, that can be accomplished with the same call. So I think that there's room for both as this landscape continues to evolve, and we're trying to build things that can potentially be used in both areas.
But we're also continuing to think of trying how to innovate in that area. We have staffing shortages in-person CMA work, and need those people to be taking blood pressures and doing a lot of the really important work they're doing in person. So we are trying to be innovative and think of, do we need to have different roles that have different job descriptions? And Brian alluded to this in kind of like thinking about some of our venues that are having telemedicine only clinics that are supported by virtual staff. Still kind of to be determined. I think with the regulatory landscape, especially Medicare, not yet being finalized about what the future long-term plan will be, it's been a little bit hard to plan to hire new staff, but we're trying to think innovatively in that area.
That's great. Any other lessons learned that you'd want to share, or any recommendations for others that are interested in implementing something similar at their organization?
Well, one piece, Brian, I think you could talk to this as well, but there are some Epic Foundation tools that are becoming available to those institutions that have Epic that may be able to use kind of readiness features above and beyond kind of what we built at our own institution, and we may be implementing those as well. You know, we're still struggling with the patient voice piece and how to best, you know, in a live fashion and iteratively understand patients' needs and how much they want to be contacted and not being over contacted. I personally have an appointment for my son today, and I have gotten 5 separate confirmation. This is not a Johns Hopkins appointment, but 5 separate requests for confirmation. So we're certainly struggling to hit the sweet spot of what does an individual patient want and need in terms of setup. Some of my takeaways.
And I think, you know, I do a lot of, with our team, comparative, what would we have done in person, pushing the boundaries to try to think about the comparable tasks for a regular in-person visit, because that makes it tangible and easy to digest. We think about that a lot clinically, right? So clinically, what are the tools we would need to do physical exams remotely? We're investing in those. Clinically, how do I arrange for a lab visit? How do I arrange for an imaging visit? What do we do about prescriptions? How do we join interpreters, which are clinical components to the clinical? And all of that is in the clinical visit, and a lot of the focus of those building telehealth programs focuses there. But the before and after is also equally important. And so how does a patient get reminded about their appointment? How do they check in? How do they sign documents? How do they upload their insurance card? How do they arrive? So that was our focus here. How do we get you to arrive successfully? Similar to how do we get transportation for you? Acknowledging that we invest in each of these pieces and have invested in them for a century for in-person equivalents. How do we break down that problem and apply it to a new workflow, a new telehealth workflow? And in person, we certainly don't solve any of those things one way. So just we need to be flexible. We need to have multiple tools in the toolkit. And you know, I think one good example, and it was briefly featured on the last slide, is one of the issues with successful video visits and arrival is waiting. So in addition to getting in, once you're waiting perhaps invisibly. How do you walk out into the waiting room and tell the patient we're running late? Well, in person, you walk out into the waiting room and you say, "I'm sorry, we're running late." You know, in many telehealth implementations, that's much easier said than done. And so how do we create alternative pathways to simply convey, please wait? And so I think, you know, each little piece of that in-person equivalent needs to be broken down and have flexible tools to execute on what obviously is you know, a complex in-person journey, and many of those translate over into the telehealth workflow.
Got a question from Eileen around this physician satisfaction from this process and increase in telehealth visits. So if you saw any of that.
We haven't measured physician satisfaction on an overtime basis. We have a very big static snapshot, so we don't have a time over time comparison. We do have trending patient satisfaction. We have over 40,000 patient surveys in the last 12 months that go out on a randomized and automated basis to our telehealth visits, as they do for our in-person visits. And as we've implemented, so a lot of confounders in that data, we've improved and changed a lot over the course of the pandemic. We have been able to isolate some of those changes, like moving to teams that, quote, specialize in virtual only scheduling and readiness. So in areas where we've been able to make that change, before and afters have shown some early signals in the patient satisfaction data that they're happier with the technology. You know, some probable reasons for that is that they're having staff who are more knowledgeable about the technology, just like more knowledgeable about the local practice. That equivalent of being knowledgeable about the local practice is being knowledgeable about the local technology. And we've started to see that signal come out in some of our patient satisfaction data. But many things have changed throughout the pandemic in healthcare, certainly in the virtual care space. And so, you know, working hard to try to figure out how to isolate some of those changes is somewhat difficult for us at this point. But.
And thanks, Brian. In terms of the reverse, I mean, at least anecdotally, there are many things that can be automated in terms of our electronic check-in process and otherwise. But certainly I think we hear, as some clinics don't have the staff to support the telemedicine visits, that it still is hard for providers. As far as would come in 20 months, it's still hard for some providers to do sessions without any support whatsoever. So having a person who can help keep you on time and make it as close to the in-person experience as possible, just like walking into the room and starting the visit, I think is a little bit of an underappreciated and important aspect for providers to kind of have smooth sessions.
Wonderful. All right, I'm not seeing any other questions in the chat. Thank you, Brian, for sharing your contact information for those that want to talk more about risk scores and EPIC discussions. Laura, I'm going to ask if you could just pull up some slides. I've got a couple of last slides here to wrap up today's session. Our next telehealth immersion event and final event of the year will be a mini boot camp focusing on what's next for telehealth. This boot camp will take place on December 7th, and during this time, we will recap highlights from the year and provide an overview of the telehealth landscape for the future, including key policy changes for 2022. In follow-up to today's event, we'll be sending out an email that you can register for this event, and we appreciate you all attending today. On the next slide is just my contact information. And thank you so much to Dr. Hughes and Dr. Hasselfeld for joining us today. We really, really appreciate it. You all are doing incredible work at Johns Hopkins, and we really appreciate you just taking the time to talk through and share that with others. Thank you all so much for joining. Have a great rest of your day.
Thank you. Take care.